Hi everyone. Thank you for joining us for today's session. Today our session's on health economics is a health economic study, and I'll, without any further ado, hand over to Namrata.
Thank you. Good morning. I'm presenting on health economic studies and critical appraisal of a systematic review that appraised health economic studies. So the structure of today's talk is understanding some concepts pertaining to health and economic studies, and then we will move on to the critical appraisal. So the first part is, why do we need health economics? So in an ideal world, we have money to afford everything, right? If you our specific target this time for these 3 weeks is anti-obesity drugs. So ideally you would have enough money to invest in lifestyle and activity, enough for meal supplements and nutrition, and enough for medical prevention and drugs. But the real world is that we don't have enough money to afford all of these. At some point we'll have to disinvest in something and invest in something else. So when we learn to appraise health economic studies, we learn to understand what gives you the maximum benefit for the money that you have and invest in that. I wanted to introduce a term called opportunity cost. Opportunity cost is what you lose out when you disinvest in one resource and invest in another. For example, when I am investing in medical prevention and drugs, how much am I losing out on investing in meal supplements and nutrition? So they allow us to compare costs and economic benefits of different interventions and allow us to choose the intervention that leads the maximum benefit for a given minimum cost. Now, when we read health economic evaluations, there are 4 major types of health economic evaluations. The first one is called cost minimization. The second is called cost effectiveness studies. The third are cost utility studies, and the fourth are cost benefit studies. These all compare costs and outcomes, but the difference is in the units. What you are studying, the costs are all expressed in rupees, but the outcomes are all different. That's why these studies differ. The first one is a cost minimization. So before I get into this, the healthcare costs can be direct, indirect or intangible. So direct costs are of the procedure itself, what goes towards the salary of the health professionals doing the procedure, the medications, the surgery, transport costs to the hospital, food in hospital. Indirect costs are loss of wages and productivity to the society from the individual and the caretaker who's there in hospital with the individual. And intangible costs are like psychological stress, pain, grief, etc., which cannot be measured monetarily. So most health economic studies actually focus only on direct costs of healthcare, and very few report indirect and intangible costs. So coming to the different types of health economic evaluations, the first one is cost minimization. So cost minimization means same drug by 3 different manufacturers. What is the absolute difference in cost? So obviously, because the drug is the same, the benefit, the magnitude of benefit is the same. So if I have semaglutide made by Pfizer, semaglutide made by somebody else, and semaglutide made by a third manufacturer, then we just compare the absolute differences in prices of all of them and look at which option costs less. The next one is a cost effectiveness analysis. So the outcome being compared is in the same unit. For example, there are 3 different drugs, but they all lead to weight loss. So drug A costs 100 rupees for 1 month and it causes 5 kilo weight loss. So it costs 20 kilo to lose 1 kg of weight taking drug A. Similarly, drug B costs 10 kilo of weight loss in 1 month and it costs 500 for a month. So the cost effectiveness analysis for this is, it costs 50 rupees to lose 1 kilo of weight using drug B. And similarly for drug C, it costs 100 rupees to lose 1 kilo of weight. So if we were looking at cost effectiveness, we would say drug A is the most effective, because at the least cost you are losing the same 1 kilo of weight. There is a concept called ICER, which is incremental cost effectiveness ratio. So what this means is that you do the difference between cost of your new drug versus your comparator and your effectiveness of your new drug versus comparator, and you compare the ratio of this. So when you plot this, the cost actually comes along the y-axis. The difference in costs come along the x-axis, and the difference in effectiveness comes along the y-axis. The slope of this line is your ICER. That is, the slope of this is called ICER. So basically, when you look at this quadrant, which is the northeast quadrant, the new drug, which is treatment A, is more effective, but also more costly. So that is the northeast quadrant. In the southeast quadrant, treatment A, which is your intervention drug, is less effective, but is more effective but less costly. So therefore treatment A would be definitely beneficial. In your northwest quadrant, treatment A, which is your intervention, is more costly but less effective. And in the southwest quadrant, treatment A is less costly and less effective. So obviously in the southeast quadrant and the northwest quadrant, you have a clear winner. Either treatment A is less costly and more effective, or treatment B is less costly and more effective. But the other two quadrants, the northeast quadrant and the southwest quadrant, whether you want to choose it or not. For example, would you choose a less costly drug which is less effective? That depends on what the effect is, right? Are you willing to pay less to lose that much of effect? Similarly, the northeast quadrant. So whether you choose the northeast and the southwest quadrant depends on a threshold called willingness to pay. Willingness to pay is basically how much money will you allocate for a particular benefit. For example, in India, an average person is willing to spend 2 lakhs to prevent an MI. That is the willingness to pay to avoid an MI in India. It depends on the country that you are in and the illness that you are talking about. So in cost utility analysis, we compare different interventions that are assessing different outcomes, and then we convert them into a common outcome measure, which is usually a QALY or a DALY. QALY is a quality adjusted life year, and DALY is a disability adjusted life year. I will come to that. So for example, in a cost utility analysis, like how we are going to do today, we have weight loss drugs, we have lifestyle interventions, we have bariatric surgery. All of these are 3 different interventions, and they all have different costs. The outcome also, some of them have expressed as weight loss, some of them has expressed, some of the studies have expressed it as mortality, some of them have expressed it as the chance of not developing a major adverse cardiovascular event. So outcomes are also different. You have to equate all of these outcomes and convert them into a quality adjusted life year. So what is the concept of a quality adjusted life year? So the y-axis is your quality of life weight, and your left axis is years in life. So for example, a person goes on for 50 years of his life at very good health. Very good health is perfect health, that is 1. Death is 0. And then there are also some effects which are less than 0, but we won't take that for now. So if he had perfect life for 50 years, the QALY for the first 50 years of life is 50 into 1. Then presuming he developed an MI at his 50th year of life, and his quality of life is now only 0.6. The QALY for the remaining 30 years of his life, and he dies at age 80. The remaining 30 years of his life, QALY is expressed as 30 into 0.625. So your total QALY will be a sum of these two, 50 into 1 plus 30 into 0.625. That is the total number of quality adjusted life years that this person has lived. So when we do a cost utility analysis, we have to convert all outcomes to be expressed as a common outcome, which is most commonly a QALY. Disability, so in QALY, the higher your QALY, the better it is. The disability adjusted life year is the opposite of this. So it is the amount of healthy life lost due to illness or disability or death. So you look at years of life lost and years of life lived with disability. For example, if you have died 10 years, if this person died at 70, then you would say the years of life lost is 10. Also, if they live 5 years with disability, for example, after his MI, 5 years he lived with severe breathlessness and his quality of life reduced further, and he had a disability weighting of 0.4. Then your years of life lived with disability are 5 into 0.4, 2 years. So your total DALY will be a sum of 10 plus 2, which is 12 DALYs. Okay. So in a cost utility analysis, we compare a cost to a QALY. The last one is a cost benefit analysis. It compares all costs in rupees, direct, indirect and intangible, to all possible benefits in rupees. And the methods you use to calculate benefits are these 2 methods, willingness to pay method and a human capital method. The willingness to pay method is the maximum amount of money an individual is able to pay to obtain a benefit or avoid a negative health outcome. And the human capital method is you assign a value to a person's life based on how much that age of a person in that society would have contributed to societal productivity. So this is the summary table of what I said. In cost minimization, you are just comparing costs of the same drug. that are available in different forms, say an original drug and a generic drug. Cost effectiveness compares rupees to a unit. For example, how many rupees does it take to lose 1 kilo of weight? Cost utility analysis compares rupees to a quali or a dally. And cost benefit ratio compares rupees to the value of a person's life or the amount, the willingness to pay threshold, that is also given in rupees. Now, before we get into the critical appraisal, I just wanted to briefly introduce the concept of a health economic model. So, many health economic studies are model based studies. Model based studies means you derive information from say observational or randomized control studies, and you have a computer model to predict what all pathways this person could go on. These are just the names of different models. I am just briefly going to talk about the decision tree model. So, in the decision tree model, say you have a you have a hypothetical 40-year-old with obesity who's entering say this arm. He is 45 years old and he has class 3 obesity. Either you can do bariatric surgery or you can give a drug, right? So, you will use say observational data to see how many people of this age with this class of obesity are seeking drug treatment and how many of them take surgery in India. So, suppose like say 0.7 and 0.3, then you make a chart as to all possible outcomes after each of the primary outcomes. So, after they take the drug, they can either be cured or they can be not cured. If you are not cured, you will give them some lifestyle intervention. If they are cured, you might switch to another drug. With the second drug, you might either be cured or not cured. Similarly, with surgery, you have to map out this entire pathway. This is just the pathway which a hypothetical patient might follow with a particular disease. And then at every step, you need to look at from data that you already have from observational studies or RCTs, what is the proportion of people. So again, you might have studies that inform you that if you give this drug, 0.7 of this will be cured, 0.3 of this will not be cured. Then further out of this, how many of them might require counseling, how many of them might go on to another drug, correct? So at the end of it, for each chain, you have a different quality value. How do you get, and for each chain, you will also have to cost this entire chain. For example, how much does this drug cost? If he is cured, that's fine. If he is not cured, how much does this drug cost? How much does lifestyle counseling cost? So at the end, you will have a monetary value for each chain and the quality adjusted life years for each chain that this hypothetical patient might follow. This is called a decision tree method. There are other methods as well. Markov, micro simulation, discrete event simulation, which all are different methods of economical modeling to study patient outcomes given a particular health condition and what treatment you give for it. So, we will get into our critical appraisal now. So, the case scenario is you are the district collector of Vellore, and you have recently read a study stating that 17.4% of young women in Vellore are obese, and you are wondering whether you should acquire anti-obesity drugs as part of the Tamil Nadu non-communicable disease program, and you specifically want to assess the cost utility of semaglutide. So, the paper I looked at for this was the paper that was published in Annals of Internal Medicine in June of this year. So, it's titled Cost Effectiveness of Pharmacological Treatments in Adults with Overweight or Obesity, and it's a systematic review done by the ACP. What I used to appraise this is AMSTA2. So, why I used AMSTA2 over CASP is because AMSTA2 allows you to look at both randomized and non-randomized studies simultaneously in a systematic review, whereas CASP is different for the systematic reviews that involves randomized control trials are different from those that involve observational studies. So, AMSTA2 contains 16 items that evaluate methodological quality of systematic reviews with 7 critical domains. And finally, you come up with an overall confidence ranking of high, moderate, low or critically low based on the number and types of weaknesses identified across the 16 items. The 7 critical domains are these. We will come to it at the end of the appraisal: protocol registration, comprehensive search, justification for excluding studies, risk of bias assessment, usage of appropriate meta-analysis, consideration of risk of bias while you are looking at the results, and publication bias. These are the 7 critical domains. and a single flaw can reduce the overall critical confidence rating to low, and multiple will make it very low. So the first question of the AMSTAR checklist, AMSTAR 2 checklist is, did the research questions and inclusion criteria for the review include the components of the PICOT statement? So the PICOT statement, basically they looked at adults with obesity or overweight, BMI of more than 25 and waist circumference of more than 35 in females and more than 40 inches in males. They only looked at studies that were conducted in the US and studies that were done after 2012. The interventions they looked at are all of these, liraglutide. I won't read out all of this, but we are interested in semaglutide. Comparators they looked at are bariatric surgery or lifestyle modification or standard of care as defined in the area that the study was done in. They looked at a cost effectiveness outcome and the timeline was at least 12 months up to lifetime. Okay, so let us look at the characteristics of the included studies. So there are 9 studies that informed this systematic review, and I have highlighted above the PICOT. They stuck to what they had initially described as the PICOT. Many of these studies, all of them mostly are government or non-profit studies. None of them are at least directly funded by pharmaceutical companies. And all of them assessed one or more of the drugs that were mentioned as intervention against any of the comparators that were mentioned. All studies were done at least for a year, but we can see that quite a few studies looked at 5, 10-year and lifetime outcomes as well. The model type, I had spoken about the models that were used to model economic studies. So all of them were modeling studies. So Markov model, Markov and microsimulation model. Then there is decision tree model that we looked at earlier. So all of these were model based cost utility analysis. Now the second question is, did the report of the review contain an explicit statement that the review methods were established prior to the conduct of the review? Basically, did they have a protocol and did they deviate from the protocol? So I gave this a partial yes. AMSTAR 2 has strict criteria for scoring it as yes and partial yes. So they had a clear review question. The search strategy was good. They had the mesh terms specified in the supplementary analysis, but they did not explicitly mention the inclusion and exclusion criteria. Through the text of the article, they have written studies like this were included, studies like that were excluded, but they have not specifically put it as a table anywhere in the article or in the supplementary. There was a risk of bias assessment done and planned as well. There was a protocol registration, but in Prospero, the protocol that links this is actually the one that we did last Saturday. It's linking to the earlier study, the study that we presented last Saturday. The protocol links to that, not the protocol for this study. Meta-analysis and synthesis plan was not applicable because they did not plan to meta-analyze these results. And there was not a clear plan to assess causes of heterogeneity, and there was no justification, there were no deviations from protocol, and they had not planned any justifications as well. So inclusion and exclusion criteria that I could find in the full text was they were only looking at cost effectiveness, cost benefit or cost utility studies, either trial based or model based. They included studies that might have used should have used a societal healthcare payer, healthcare sector, healthcare system or patient perspective, and only English peer reviewed studies done after 2012 were included. Now exclusion, they did not use studies that were solely looking at cost minimization analysis. And they also excluded studies that reflected only medical treatment costs. In the sense, they wanted to look at studies that also included downstream costs and indirect costs. And they also excluded studies that received funding from drug companies. Now the third question is, did the review authors explain their selection of the study designs for the inclusion in their review? So they had said that they want only cost utility, cost benefit or cost effectiveness analysis. There were no RCTs that informed this systematic review. Out of the 9 that they included, 6 were model based and 3 were from systematic review and meta-analysis. For the studies that they excluded, they have just written that they were excluded because of study type. They have not written what type of study it is actually. Did the review authors use a comprehensive literature search strategy? Yes, they did. They looked at Medline, Embase, International HTA database, and all these special databases for looking at health economic reviews. The reason I gave this a partial yes is it is not written whether they searched bibliographies, contacted content experts, or looked at grey literature, which by Cochrane standard should be done for a health economic study. But the searching of the databases per se and the number of databases they included were good. Did the review authors perform study selection in duplicate? So yes, at least 2 authors independently screened references in duplicate on the title and abstract, and thereby the full text after that using EPI-reviewer, and disagreements were consulted with a 3rd reviewer. So the only critique I have here is they did not mention a percentage statistic for agreement between the 2 reviewers. Did the review authors perform data extraction in duplicate? Yes, they did, and they again resolved disagreements with the 3rd reviewer. Did they provide a list of excluded studies and justify exclusion? So this is a sample that they have in the supplement table. They have reasons for exclusion, but they don't have just the justification. So that was one critique. This is the Prisma flow diagram. So they initially identified more than about or nearing to 2000 records. They removed 82 duplicates, and they finally had 1418, of which they excluded 1317 records. So that's a large exclusion, but they had a very strict inclusion criteria, because their specific reason for doing this was to actually inform the American guideline on obesity. So that's why they were clear that they will only take American studies done after 2012 with one of cost benefit, cost utility, or cost effectiveness. Finally, they took 101 reports for retrieval, and they assessed 95 for eligibility and included only 9. Did the review authors describe the included studies? Yes, they did describe in reasonable detail. They had a table which we already saw, which had the pie chart of all the studies that they had included. My only critique here is when we are looking at health economic studies, actually it is important to know whether it is an original drug or a generic drug, what is the dose that was given, what was the formulation of drug used, is it subcut or oral. So those things are also supposed to be mentioned when you are mentioning details on the intervention and the comparator, which was not done in this study. Did the review authors use a satisfactory technique for assessing ROB in individual studies that were included in the review? So I have given this a partial yes. So they did this, the ROB for this systematic review was done using a tool called the check tool, which is criteria of health economic quality evaluation. What they did was, out of a theoretical maximum of 92 points for quality assessment, they classified studies as having low, high, or very high risk of bias. So actually Cochrane has a guideline document for economic studies, and they have suggested that you use Robin 1 for ROB and check for the methodological rigor of the study per se. So this is the tool that they have used in this study, and this is the Cochrane document that I was talking about. So in this document they have suggested that you use check for methodological quality, and you use Robin 1 for model based economic study evaluation for the ROB for that for model based study economic studies. But anyway, the authors here use this tool called check, and they have in their supplementary they have titled it as quality assessment, not as ROB, but they have presented the ROB. So the domains it looks at are actually 24 domains. So overall there are, I've just put this up so that we know what domains. Is there a question? Is it an objective measurable outcome? Are the opportunity costs appropriately measured? is the analysis appropriate to answer the research question, and going on, there are 24 questions like this in this check criteria, and finally, yeah, I'll come to the number of risk, the risk of bias. So this is what Cochrane has, this is the checklist that Cochrane has suggested that we use for methodological rigor, not for ROB. This is the CHEC criteria, not the CHEQUE criteria, and that has 19 questions to look at. So did they report sources of funding? Yes, the sources of funding for all the 9 included studies are mentioned, and it is mentioned that studies receiving industry funding have been excluded. They have not performed a meta-analysis, so these questions are not applicable. So coming to the results now of our study, this is just a cartoon. So before we look at the results, so like this person is telling them that we should do a cost analysis, and whatever it is, you should say it's a good investment. So the person is saying, I should not have gone to college, and he said, yeah, that's because someone told you that college is a good investment. So available comparisons in this paper, they had cost effectiveness of liraglutide that was reported in 8 assessments, naltrexone, bupropion, which was reported in 5, phentermine topiramate, which was reported in 4, semaglutide they had 20 assessments, and tirzepatide they had 5 assessments. So this is the results table. Let's just look at the on the top we have the study year and reference, and then we are looking at whether it's a healthcare perspective or a societal perspective. We have the time horizon, like anywhere 1 year and upwards up to lifetime. Incremental costs is the difference between liraglutide versus lifestyle, or bupropion versus lifestyle. Then we have incremental effects, which is the same thing. The difference in QALYs between liraglutide and lifestyle, difference in QALY between naltrexone, bupropion and liraglutide, and lifestyle. And then finally we have the ICER, which is the division of these two. The incremental cost divided by incremental effect gives you the ICER per QALY, that is in dollars per QALY. And then we have an interpretation of the economic value, the probability of at least attaining an intermediate value, and the certainty of evidence. So before we start looking at this, we have to see that we have to look at the willingness to pay threshold. So they had defined that by the clinical guidelines committee, a high value is if your ICER is below $100,000. That would say that it is a high, below $1 lakh is a high value treatment. If you have an intermediate value treatment, the ICER will fall between $100,000 to $200,000, and a low value treatment is if your ICER is above $200,000. So what I have highlighted are the ICERs that fall below the high value threshold. So if you look at it, the phentermine topiramate arm, when you look at it from the healthcare perspective, it costs only $8,000 per QALY. And if you look at it from the societal perspective, it costs $85,229 per QALY as compared to lifestyle modification. These are the other 2 significant results that this table informs us of, tirzepatide versus lifestyle. So all of these QALYs are mostly below 100,000, and a few of them are below the intermediate value, 200,000. And semaglutide versus liraglutide also has an ICER value of $31,000 from a healthcare perspective, and $12,000 from a societal perspective. This is comparing these drugs to surgical standards of care, and there was nothing, there were no economically beneficial treatments that were found here. So a summary of this table, a written summary is tirzepatide versus lifestyle had a high value, phentermine topiramate versus lifestyle modification had a high value, semaglutide versus liraglutide had a high value, and the low value comparators that they found were liraglutide versus lifestyle, semaglutide versus bupropion, and semaglutide versus phentermine topiramate. The only critique I had here was that they didn't provide 95% confidence intervals for their reported ICERs. Now, one more thing that they have gone on to do is a sensitivity analysis and a subgroup analysis. So, in a economic study, what does a sensitivity analysis looks like? Look at it asks that if I change the discount rate or the treatment cost or the probability of adverse events, does my ISA value still remain beneficial? For example, 10 years down the line, if tercepetide is cheaper than, okay, not tercepetide in this, okay, maybe like naltrexone bupropion is cheaper than what it is now, will it still be more less beneficial compared to lifestyle intervention is what we are looking at. So, they varied treatment prices from 100% decrease, which basically means they looked at if the drug was free, compared to 50% increase, and they also looked at a varying mode of administration of semaglutide, oral versus subcutaneous. So, they found out that both oral and injectable semaglutide were of high economic value when comparing to lifestyle intervention. Tercepetide versus oral semaglutide, the ISA value was, which means tercepetide had was more cost beneficial, and adjustment for inflation decreased the economic value of tercepetide versus lifestyle modification. So, this is a sample of the sensitivity analysis table that they gave. So, when they looked at this is oral semaglutide, so it is still below the willingness to pay threshold when compared to lifestyle modification. Our threshold for willingness to pay for high benefit is 100,000 per quali, $100,000 per quali, and this looked at both these perspectives had $75,000 per quali and $62,000 per quali. In a subgroup analysis, you ask whether the treatment is cost effective in different patient populations. For example, if I change the class of obesity that I am looking at, or if I am studying older individuals, or if I am looking at only obese males, is tercepetide still as effective, right? So, for this, the summary of this is that they found that topiramate was of high value in class 1 obesity, whereas in other subgroups it was of intermediate value. Tercepetide was of intermediate value for class 1 obesity and class 2 obesity compared to lifestyle modifications, whereas in other subgroups it was of low value. This is a little counterintuitive. You would expect it to be more beneficial in higher classes of obesity. Cause and effects of tercepetide and phentermine topiramate were lower in the subgroup of, which means in older people all of this was less beneficial in a cohort more than 65. And naltrexone, bupropion, phentermine topiramate and semaglutide and tercepetide were all found to be of low value in patients with diabetes compared to lifestyle intervention. So, back to our appraisal. Did the review authors account for ROB in individual studies? So, I gave this a yes. So, in the grade requirements, these are the 5 domains that you have to assess. What did they use to assess it in this systematic review is what I have put on the right. So, the ROB they did using a check tool, and they found out that out of the 9, 4 had low risk of bias, 2 had high risk of bias and 3 had very high risk of bias. Then inconsistency, actually grade does not have clear recommendations on evaluating inconsistency for health economic studies. Indirectness, they again looked at the check criteria. Imprecision was by ISA thresholds, but they did not report the 95% confidence interval, and publication bias may not need to be done for model studies. So, this was the grade assessment, risk of bias, inconsistency, indirectness, imprecision, and then finally they had a certainty of evidence. Normally there are 4 circles in the certainty of evidence for grade, there are only 3 here. So, one thing I wanted to highlight here is grade is always done for a specific pairwise comparison for a particular outcome. It is not done for the entire systematic review across studies. So, final certainty of evidence, they had in these 9 model based cost effectiveness studies, there were 42, they had 42 pairwise comparisons, out of which 0 of them had a high certainty of evidence, 6 had moderate certainty and 36 had low or uncertain certainty of evidence. So, this is the document that I was talking about. So, grade is still in the process of developing a guideline for appraisal for health economic studies, and this is the link to that. And did the review authors provide a satisfactory explanation and discussion of any heterogeneity observed in results of review? So, I felt that they did not, because even though it is not mandated that you, there's not a mandated way to deal with heterogeneity in economic evaluations. For example, in this table, in this results table, look at semaglutide versus endoscopic sleeve gastroplasty. So either semaglutide is saving money for weight loss versus endoscopic sleeve gastroplasty, or you are spending an extra $200,000 for the same weight loss benefit versus surgery. There's a big difference, and this heterogeneity they have not addressed, and they have not explained also in the systematic review. So if they performed a quantitative synthesis, did the review authors carry out an investigation of publication bias? No, they did not do that. And finally, did the review authors report any potential sources of conflict of interest? So they have mentioned that ACP funded this review, they provided input for all the key questions, inclusion criteria, but they were not involved in data abstraction analysis. So it was a non-funded study, but like who's funding ACP, we don't know. So overall critique is, of the 7 critical domains in AMSTAR 2, definitely they did not address publication bias. The others were all sort of addressed in the paper or fully addressed. So overall rating of confidence is low. The limitations that I found in this study was there is a narrow scope of generalizability, but I mean for their question it was okay, but like we cannot generalize these results to our population probably. They have not mentioned if original or generic drugs were used. We don't know at this point whether you can use multiple health economic studies and pool their data, or can you even, like how we discussed last week about indirect comparisons in systematic reviews, can you do this for health economic data? We don't know. There were no RCTs that were identified, and everything was because it is model based assumptions, we don't know whether these outcomes are true or not true. For example, whether fentramate, topiramate or other non-GLP-1 receptor agonists reduce cardiovascular events is unknown. But when you make a decision tree, one arm is that they will reduce cardiovascular events. So because it is model based, you don't know whether actually all of these in truth are effects of these drugs or not. Details on doses of drugs and lifestyle interventions are not available. Details on adverse effects were not available, and 95% confidence intervals for ICERs were not reported. Finally, we are coming to whether we can apply this locally or not. Would the results of this review represent greater or additional benefit for the persons or population that you are responsible? So I just did a quick costing. Oral semaglutide is given as an incremental drug dose. So for 1 year in our pharmacy, it comes to about 2,73,000. Cost of lifestyle intervention for 1 year. So I just took Healthify Me 1 year annual subscription cost. So that actually costs, if you are taking a doctor-led program, it is much more than this. It's double this cost. So presuming you use an app-based weight loss lifestyle intervention program, it's about 35,000. So the cost difference between these two is approximately 2,40,000. Now we don't have an Indian study that gives us the effectiveness difference between outcomes of semaglutide use in weight loss. So I just took semaglutide versus lifestyle modification from this study. Okay, so this is the incremental effect of semaglutide versus weight loss, but this is not in our scenario, but for lack of evidence I did this. And then the ICER formula is you divide these two. So in India, presuming that this is true in India, the 0.9, in India our ICER value would be 2,66,000 per quali to use semaglutide versus lifestyle intervention. Now what is our willingness to pay in India? It's estimated as 1 to 1.5 times our gross domestic produce. So in India you would spend 2,12,000 to gain 1 quality adjusted life year. But our semaglutide is costlier than that. So I would say that it is not cost effective. So in my case scenario, if I was wondering should I invest in semaglutide, I would say no. Thank you.